Good afternoon, everyone, and welcome to Grand Rounds. My name's Tom Fardon, and I'm the chair and organiser of Grand Rounds. I apologise for my husky voice today. I was on annual leave last week and did a lot of shouting for reasons that are not as sinister as you might suspect, as I was supporting my son's rowing team down in the races down in Cambridge, and it's led to me not being able to talk very well. Fortunately, you don't have to listen to me very much for the rest of this, as I'll be handing over to our invited speakers, Dr. Kirsty Colquhoun and Dr. Kerri Baker. It's always a pleasure to have invited speakers, and I was in a meeting with Kerri a few months ago, and she happened to just drop into conversation that she and Kirsty are doing what she described as a tour of Scotland, talking about disability and about gender inequality. And I thought immediately, well, that'd be great for a Grand Round presentation, and pounced. And so I'm very pleased that they both agreed to come and speak today. Kirsty is going to kick off first. She has to leave at 1:30, I'm afraid. So if you have any questions, do put them in the chat so she can tackle them before she departs. And then we'll move on to Kerri's talk. So Kirsty is a consultant geriatrician in NHS Greater Glasgow and Clyde with a special interest in oncogeriatrics, and is sub-dean of the University of Glasgow Medical School. But on this occasion, she'll be talking about supporting the disabled workforce and the disabled patient. Kerri Baker is a consultant in acute medicine in NHS Fife, and also one of the associate postgraduate deans for medicine, specifically IM stage 2. Across all of Scotland, and she's going to speak about gender inequality for doctors, healthcare professionals, trainers, educators, and also patients. So we'll start off with Kirsty, who's going to talk about disability. If you do have any questions, please put them in the chat, or if you're brave, you can put your camera on at the end of the talk and ask your question in person. Kirsty, thanks very much for taking the time to come and speak to us, and to Kerri as well.
Thank you very much for having me. So just before we start, I always put this up at the beginning, and I just kind of want to have a bit of a pause, and I want you to think about the first thing that pops into your head when you put the word disabled or disability up. You don't need to tell anybody, and it's just to think about what it brings to mind. Is it positive? Is it negative? Is it based on your own personal experiences because you're disabled, because someone near you? Is it based on professional context? Is it based on media? And it's fine, because we all have formulated thoughts and ideas based on experiences, but I suppose it's thinking about how that would impact on disabled people moving forward. And it's just I think to highlight that we all have unconscious biases, and that's fine, and it's just being aware of them so that we make sure that they don't impact negatively moving forward. And I think increasingly, unfortunately, disability is portrayed negatively in the media and things like that. So that was the first thing. So, is it going to move? It doesn't seem to be moving forward. Sorry, I'll try it this way. Oh, right. Sorry, I'm going to have to do it that way. So, the aims of this essentially are going to be to understand the challenges faced by the disabled workforce, and that will kind of tie in with the disabled patients as well. Understanding the benefits of embracing a disabled workforce, and again, applicable to other protected characteristics, and what we can do to promote disability inclusion, and a little bit of a personal flavour. So this is sort of my day-to-day job, which will be very similar to all of yours from my clinical perspective. So I suppose you're all looking and wondering, why on earth am I talking about this? So this was me when I was, I don't know what age I was, pretty young, and the eagle eyes people there might see that I've got splints on. So I was born 10 weeks premature, and I was diagnosed with cerebral palsy. So cerebral palsy is obviously a very broad condition which can affect people in lots of different ways. For me, I've got spastic diplegia, so it affects my lower limbs. So and I'm lucky I don't have any of the other associated conditions that you could have. But if you saw me walking, you would notice that I'm a bit slower, a bit off balance. So if I was going, I don't use any walking aids, I can walk independently. But for example, if I was going up and down stairs, I would use a banister. I can't really run. So that's where I'm coming from. I didn't really talk about my disability at all in my professional capacity until I was well into being a consultant, well into my 30s. And then I started working with a cerebral palsy charity and ended up doing various different roles, which I'll talk about later. So is it relevant to me? I was certainly aware when I started working, and still, and I kind of look about and I don't necessarily see a lot of people that are disabled in the workforce. So it might not feel that it's that relevant, but actually 20% of the working population are disabled. Only 2.9% of the clinical workforce in the NHS have a declared disability. But of course, what we need to think about is the fact that disabilities come in all different shapes and sizes and forms. We can have visible disabilities, something like mine, but there's also hidden disabilities, chronic health conditions. And of course, as we age, we're more likely to acquire a health condition, acquire a disability. And so we might think it doesn't impact us now, but we don't know what might happen in the future, either with us or with colleagues. And I think, as we've seen with COVID, of course, disabilities aren't just about physical health conditions. It can also be things, but be mental health issues, and we've seen a massive increase in that. It can be long-term, it can be short-term, can be fluctuating. And I think particularly when we were dealing with the medical students, people with fluctuating disabilities, sometimes people struggle with the idea that one day someone might need a seat if they're in theatre observing, and the next day they don't. They might struggle a little bit with. But the other thing to think about as well is carer roles. So we might be working with a colleague who has a disabled child, disabled partner, disabled parents, and how do we support them in working flexibly? So there's lots of different things in which this ties in with, even though we maybe don't initially think it's not relevant, it's relevant to us. We talk a lot about equity, diversity, inclusivity now, and people just say, well, why don't we talk about equality? And this is kind of applicable to all sorts of protected characteristics and also social deprivation. It's become a bit of a demonised term that this is just woke, it's a waste of time. But essentially, EDI and issues like we're discussing today is a human rights issue. It's about access to healthcare, it's about access to employment, it's about access to housing. And we know that people with protected characteristics, disabled people, particularly people with learning disabilities, have massive health inequalities. So when we talk about equalities, so the reason I talk about this is when I was young, primary school, everybody wore these dainty shoes, which I have in my head called princess shoes, the bottom ones, and I couldn't walk because before I got all my surgeries, I used to walk on my toes, scuff through my shoes and have holes in them. So I was about primary 3. My dad bought me these chukka boots, which had steel toe caps in them, and to make it what he thought better, but I felt worse, added in these luminescent laces. So everybody was walking about in these dainty shoes, and I had these massive big boots. So equality is this idea that everyone has a pair of shoes. Diversity is everyone's getting a different type of shoe. So I was getting different types of shoes. I was getting a shoe, so the equity that fitted me. But what is difficult is this inclusivity side of things, this accepting that everyone might wear a different pair of shoes. And actually, despite the fact that I was wearing a different pair of shoes, it didn't matter. And I would still be included in friendship groups. I wouldn't be teased. I wouldn't be bullied. And so I think it's this part that is the challenging part within what we do within the NHS, or the hardest part. And of course, all of this ties in with Civility Saves Lives as well, the way in which we talk to people, the way in which we treat people, the way in which we make people feel. And if you haven't looked at Civility Saves Lives, if you just put it in to Google, you can see the website, and it's certainly really worth having a look at. And if you've not done a ground round on it, it's certainly worth doing that. If we think about disability, as I say, the occurrence of disability obviously increases with age. And there's no doubt that if you are disabled, life is harder. And I realise that I am very lucky in the way that it's impacted me, but it doesn't mean that life isn't a bit harder. And certainly it's worth considering that when we see our patients. So you have the issues around about the physical side of things, or if you have a mental health condition, the impact that that has. So the symptoms essentially, so with me, it would be pain, the physical things that I can't do. But then the other challenges, so employment rate is a lot higher. For some people, it may well be related to the disability, but for a lot of people, it's related to attitude. And I've recently been been on an unemployment panel, and that is one of the big problems. Life certainly costs you a lot more, and actually now that figure is above £1,000 more per month on average. And if we think about that in a cost of living crisis, then that's really very significant. And we need to think about in the context of patients being able to access healthcare, can they get up, etc., at a hospital and things like that. Tying in with that, the fact that over a quarter of disabled people are living in poverty, which is slightly higher than the general population. And again, this way that people see them, so 1 in 3 people see them as being less productive. And I think certainly the current media isn't helping that. And 3 out of 4 people have often experienced negative attitudes or behaviours in the past year. And I think even myself, where I pretty much do everything that everyone else does, I still face that. What about if we look at it in the context of the NHS? I think people think, oh, the NHS, we're a caring profession, so it's all going to be rosy and there's no problems. When the BME did this survey, 2019 released in 2020, and I suspect, given the current pressures that we're all working in within the NHS and the workforce issues, I'm not sure that this would have improved, but obviously I can't say. But 55% of disabled doctors and medical students who required reasonable adjustments had them, but that means a big significant number didn't have the reasonable adjustments that they required. And that might be the difference between being able to work and not being able to work. A lot of people, most people, were worried that if they disclosed a disability or a long-term health condition, then perhaps they would be treated unfavourably. And perhaps that is why we have this kind of mismatch between representation in the NHS workforce versus the population. Only 41% said that telling their workforce had led to improvement. So 60% of people had not had improved support. So why would you tell then and declare it unless you really had to? And you can see less than 50% felt that their colleagues had been supportive. So that's really quite depressing reading. If we think about, yes, we are meant to be a caring profession, and that's how we make our disabled workforce feel from a medical student and a doctor perspective. This is an English system, but it is very interesting if you wanted to look. So it's basically the National Workforce Disability Equality Standard Report. It's produced every couple of years, and it benchmarks each trust. So you can kind of benchmark against each other, or you could benchmark yourself year on year to see if you're improving. And essentially, all the data comes out that disabled people score sort of poorer compared to non-disabled colleagues. So in things like when they talk about representation, so there's actually 12% of health boards have nobody with a declared disability in leadership positions. And when I read that, I thought, well, maybe that means like CEO or CD, and like there's not that smaller proportion, but actually that means things like band 6 and above, so nursing, AHP colleagues, consultants, any kind of non-clinical managerial position, service manager and above, so really underrepresented, and certainly in terms of percentage, significantly more likely to be harassed, bullied and abused. And one of the interesting things to talk about is presenteeism, which I think all healthcare workers are probably a little bit vulnerable to, so we'll be coming back to work sooner than perhaps we should if we're unwell, and pushing ourselves through things. So that's just some of the things, but these are the sort of things they discuss in that. So it's an interesting document. And of course, why does this matter? Well, there's a ton of evidence around about inclusion and why making sure you have a broad workforce is really positive. We know that it's much better for retention and recruitment if people look about and they see that their workforce represents all the different people in society, then they have a much higher morale. And obviously in the current climate where we're facing such a big workforce issue, that is like really important. Imagine tomorrow you or your colleague, heaven forbid, were in an accident and had, let's say, a spinal cord injury and had to use a wheelchair. Now, that does not mean that you cannot work, you have a vast amount of skills. You might just need to have things adapted for you. Could you imagine how you would feel yourself, how you feel as a colleague if no one was willing to make any reasonable adjustments, and so that was your job gone, as well as all the other things that you had lost. It's also really important to have a representative workforce, again, not just talking about disability, but all of the protected characteristics, and in terms of deprivation, it's important that the workforce represents the population. And we know if we do that, then we help to reduce the health inequalities that our patients face, and obviously improve their health outcomes. So as I say, this is not woke, this is about improving people's and society's health. There are a number of barriers to accessing healthcare if you're disabled, and the UN, this is sort of the UN sort of discussion about that. So attitudinal barriers, and I think we think about physical barriers. You know, I work in a really old hospital where the lifts are constantly breaking down. There's not enough car parking spaces, even blue badge spaces, but people still do feel attitudinal barriers from the way in which they are spoken to, particularly maybe medical professionals don't expect them to do the things that they want to do. Communication barriers, and I was mortified about a year ago. I had a deaf lady on my ward, and I was told she could lip read, so I would talk to her, and then she went to another meeting and she said she wasn't feeling included in discussions because she wasn't getting an interpreter. So I was mortified about that. I should know better. But these kind of issues as well, and it's hard, isn't it, if you're really, really busy, you're short of time and you're going out, but these things are really important. And the financial barriers that we have talked about already, we know disabled people are more likely to live in poverty, their cost of living is higher, so can they afford to get up and down to their healthcare appointments? Particularly things like screening are poorly accessed. So what do the GMC think about the disabled workforce? Well, they've got this document, Welcome and Valued, Supporting Disabled Learners in Medical Education and Training. So disabled people should be welcome to the profession and their contribution to patient care. No health condition or disability by virtue of its diagnosis automatically prohibits an individual from studying or practicing medicine. But obviously we know that there will be some disabilities, there will be some health conditions that mean that you won't be able to practice medicine. So essentially, you obviously have to meet the criteria to get into medical school. When you're going through medical school, there are things that you have to meet in order to progress. So even if you've passed medical school, there's certain criteria that the GMC set out that you have to have achieved in order to get your registration. Now, you can, if you can do that with reasonable adjustments, then that's fine. And people seem to often freak out about resuscitation, but you know, if you're in a wheelchair, just because you can't get yourself onto the floor, that doesn't mean that you can't pass resuscitation. You know, you're still able to do it in another way. However, when you talk to the GMC, one of the examples they gave was of someone with dyspraxia who, and one of the things you have to be able to do is take bloods, and no matter what adjustments were put in place, they weren't able to do that, and so they couldn't fully register. So I think it is important setting out that actually there are going to be things that you're going to have to be able to do. And if you can't meet those, even with adjustments, then you cannot fully register. And then, of course, having a health condition or disability alone is not a fitness to practice concern, but it depends whether that would impact on a person's ability to practice medicine safely. And obviously that's case by case. And, oh, sorry, someone's come. And obviously that depends on, and obviously that's the individual situation. And that is, I think, where medicine is slightly unique compared to other health professions. If you're working in an office and you're disabled versus here, where obviously patient safety is paramount and has to be taken into consideration. So I think we do have to have a pinch of realism. I think we live now in a society where we all think we can have everything. And I think if you're born with a disability, as well as people being born with all sorts of different challenges and facing lots of different challenges, and we all face lots of different challenges as we go through life, that we're not all going to be able to do everything. And I think you need to think about how you will cope with the challenges that you'll face and be realistic about the fact that medicine isn't just hard, and people think about it being very bookish and having to pass exams, but it's a very physically and emotionally demanding career as well. And I talk to a lot of school students who do have health conditions and disabilities, and they'll chat to me about whether, and I can never tell them whether they're going to be able to do it, but I can sort of set out and help them see what it's going to be like, what the challenges may be. Reasonable adjustments is a tricky thing. It's not like you can sit and say, well, these are a list of the reasonable adjustments, because everyone is so different. So even if you go to occupational health, they'll make some guidance, but it's actually the organisation that deems what's appropriate in terms of a reasonable adjustment. And there may well be a bit of a mismatch between what an organisation thinks is a reasonable adjustment, what a person thinks is a reasonable adjustment for them, and actually both could be a bit out of sync. So that is a challenge. So I just wanted to talk a little bit about, I guess we talked about how we all can't have every experience of every patient, obviously, but if as a workforce we have lots of different people who can bring different perspectives to the table, then as a whole we can make hopefully a healthcare system that is fitting for our population. So I talked about how I have cerebral palsy. One of the things that you may or may not be aware of is there's actually no adult services, or there's very patchy adult services. So if I had a different type of neurological condition, I might have a specialist nurse, I might have access to specialist AHP. There's nothing really like that for adults with cerebral palsy once you kind of hit, beyond paediatric services. And I think that's because it's seen as non-progressive, but of course it's not a static condition. So this is a 73-year-old man who came with his sister to my general clinic. He had spastic quadriplegia, so all 4 limbs were impacted by his cerebral palsy, as was his speech. He'd been actually referred by his GP with weight loss. He had a background of colorectal cancer, which had been resected. His sister kind of said, and she was feisty, his sister, I liked her, and she said no one had bothered with him. They told my mum he wouldn't live beyond 12, so essentially no one had bothered with him since then, and kind of thought that he should just feel lucky that he was still alive. And he sort of said, metaphorically and literally, no one had listened to him. He'd never had any kind of aid to help with communication. And now there's actually legislation in place in Scotland that you do have to have a communication aid and you have to be shown how to utilise that, but no one had ever given him that. He used a wheelchair, he required assistance with all his activities of daily living, but there was no formal package of care in place. So we referred him to a charity where he was able to access specialist AHP support and so they could support our local AHPs. He was referred to Westmark, he got a new wheelchair. That wheelchair actually had a special, his sister was in her 80s and it had a special sort of handle, so it was easier for her to push. It was referred to orthotics, he was given a new raised shoe, it was referred to speech and language therapy, he was given his first ever communication device, which was fairly simple, it was just an iPad. He was put on a staged diet, he was referred to dietitians, and all I did really was address his pain and his mood. He had a lot of osteoarthritic, osteoporotic issues which had never been addressed. And obviously, given the fact that he was having all these issues, his mood was pretty low. There was no other organic cause of his weight loss. It was essentially because he was sitting in a misfitting wheelchair, all stooped over, struggling to swallow, lots of secretions. And all those things, his posture improved, his pain improved from 8 out of 10 to 3 out of 10. I mean, imagine living your whole life with a pain of 8 out of 10 because no one had really bothered to ask you about it. Sleep had improved because the pain was better, because he was eating better, he was gaining weight. Carer stress was markedly reduced. They still didn't want any carers, but just these measures had helped. Didn't need anything like antidepressants, his mood had improved. And remarkably, the day centre he went to was because basically he was able to walk in now with his relator rather than using his wheelchair all the time. And so I think the barriers for him were recognition. So people just presumed that he had reached a point, he was at his most able, but actually there was still loads and loads of things that we could do. And because I was coming from that point, I could help. The lack of education and research in the area, the lack of specialist care, and again, these societal attitudes that he'd felt when he was really young that had been kind of carried through. And I think the services we now value, or what feels like we value, are basically getting patients out of hospital as quick as possible, keeping patients out of hospital. And if you don't meet any of those kind of criteria, then it's somewhat tricky. This was basically a report produced about older adults with cancer by Macmillan and by Age UK and NHS England, and it's basically older adults should be put in that, are in those missing bits. But I think you could put in lots of different protected characteristics into that. You could certainly put disability into that and it would still fit. So there's a lot of overlapping issues between the different protected characteristics. So I mentioned a little bit how I got involved in this. So as I say, till I was in my 30s, I didn't talk about my disability at all in a professional capacity. I didn't want to be the disabled doctor. I wanted to be valued as a doctor, rightly or wrongly, whether that was the right thing to feel, that's what I felt. And then, as I say, I became a trustee for Cerebral Palsy Scotland. It was a charity formed nearly 30 years ago. My mum and dad were founder members, so then I ended up getting involved. I then ended up getting involved in all these parliamentary groups trying to tackle health inequalities for people with disability and cerebral palsy. And that led to things like being physician representative from the Royal College of Physicians and Surgeons EDI group, and then doing that EDI role within the University of Glasgow, and then work with lots of different organisations. So going from not wanting to talk about it at all, I've ended up talking about it quite a lot. So as I said, I always felt really quite uncomfortable talking about it. I didn't want people to judge me. I didn't know what people would think about me. And this was World Cerebral Palsy Day, I think it was 2021. And I just thought, I'm going to try and get the lights of the Queen. I don't work in the Queen Elizabeth, I work in the Royal, but they have these lights. And I was like, I'm going to try and get these lights to go green. And essentially to do that, I had to kind of sell my soul. And I ended up in all the newsletters about talking about cerebral palsy, what it is, what we can do to support patients with cerebral palsy and other disabilities. This is my CD, that's the director. The Royal College started to support it, started doing a little bit of work around about the British Geriatric Society, who I do other work with, looking at about how we support adults with disabilities to age well and how we support older adults who've had lifelong disabilities. So suddenly it all ballooned, and I think that was the first point that I felt, actually, I probably don't need to worry about this so much. And I did feel like a valued member of the workforce, regardless of whether I had a disability or not. So that was quite powerful, and I think tackles this idea of being an active bystander. And I'm just going to put this up. I think it's really powerful. And essentially active bystander training gives you tools that if you see people acting inappropriately towards somebody, often in the context of protected characteristics, particularly racism, then different tools you can use. Now, again, this is something that's quite separate, but does tie in with all of this and is something that's worth looking up. Our health board have now got active bystander training as part of our wellbeing group that everybody in the health board can access. If you have a or you are disabled, then I think this would be the best resource to look at. Sorry, it's a little bit small. It is essentially an organisation, a group run by disabled doctors at all different points in their career, with all sorts of different health conditions, having acquired them at various different stages. And it would give you guidance right from applying to medical school right through to retirement. So I would say this is the best website to look up, as well as the sort of other documents that I have shown you. But from a practical perspective, if you have somebody that's needing support, this is worth looking at, as well as, of course, your local things like occupational health, like if you have a disability network within your health board, which we do. And I think it is important that we recognise that our disabled patients, our disabled colleagues are just like us and just are like that, are wanting to do all the things that we want to do, and not to underestimate people. I think we often do underestimate people with disabilities. I also think it's really important that we recognise that in order to be something, you need to see it. So when I was applying to medical school, I was told that I shouldn't apply. And I didn't get into a couple of medical schools one medical school based on my disability. This is my friend Susie. She's 4 years older than me. We swam together when we were young. She is spina bifida, she uses crutches, so she was 4 years ahead of me in medical school, so I thought, well, if Susie can do it, I can maybe do it too. She's now a consultant psychiatrist, and that was us swimming a couple of years ago. The guy at the bottom, he has cerebral palsy, he has hemiplegia, and he has completed the 4 majors marathons. He runs a marathon in about 4.5 hours. Elaine Boyd, she is in Audit Scotland as a director. She's an accountant. That's her flying a plane. And then that is an MP that I have met through the All Party Parliamentary Group, and he also has cerebral palsy. So I think not underestimating disabled people and what they can do is important. So in summary, the disabled workforce and patients face many challenges. There are many benefits to including disabled people in your workforce, and there is an overlapping skill set when we're looking at other protected characteristics, health inequalities, including deprivation. My experience actually has been overwhelmingly positive. So I do want to share sometimes my story a little bit so we don't put people off if they just look up that BMA survey and things like that. And that's me. So I'll stop sharing so I can see any questions.
Thanks very much, Kirsty. That's really fantastic talk.
Sorry, someone coming in the middle to give me my dictaphone back.
That's all right, don't worry. It's real world stuff, isn't it? You mentioned in the middle of that the civility save lives, and you'll forgive me for multitasking during your talk, but I've been onto their website and I've put in a request for them to come to Grand Rounds already. So that's very helpful. Thank you.
It's really good. It's a really sort of inspiring talk to see as well.
Well, they have a TED Talk which you can watch on YouTube, and I'm hopeful that they will come along. They're based in Coventry, but also they could zoom in from anywhere. So so that hopefully they'll come along, and if they do, I'll let you know. I'll give you a credit for letting us know about it. Steph Sim has said, brilliant talk, thank you. I'm currently injured, Achilles tendon rupture due to enthusiastic ceilidh dancing, and I've become even more aware of how difficult the access to Nine Wells Hospital is for people with mobility issues. We all know that the Nine Wells parking is awful and it's bad enough as a patient, but do the organisation have an obligation to make access easier for disabled staff? So I think that's just a general question about organisations, rather than, I'm not expecting you to answer on behalf of the Nine Wells Hospital.
So they probably should do, but it's really challenging because obviously parking is such a issue for everybody. When I asked occupational health, because my parking permit was a mile away, and basically if it was like icy, I couldn't get to it at all. And they said that they couldn't have anything to do with parking permits, and that was the states. But actually then what happened was I applied to a blue badge because my physiotherapist told me I was being ridiculous and I should apply to a blue badge and shouldn't be Ubering my way around the world when the weather was bad. So that helped. So what I've been told is occupational health, certainly, and our health board can access temporary permits. So if you have something like that, if you've got a broken leg or something, then they can do that. But I don't know what they do from the practical issue of you come in the middle of the day and all the spaces are full. I mean, I don't know how they get around that. I think people are relying on people dropping them off.
Yeah, it's difficult. What Steph needs is a friendly neighbour to help ship her around, perhaps.
Not ideal.
Hand up, Mia Malik. Sorry. Yeah.
Iqbal, hi.
Hi, Iqbal. Sorry, you were a tiny little picture. I couldn't recognise it was you.
No, don't worry, no problem. Kirsty, thank you. Part comment, part question. Thank you for a brilliant talk. Having worked with you before, I think you certainly opened my eyes to a lot of different things. You've talked a lot about institutional things and how the national EDI strategy is. What can we do as individuals, apart from the active bystander? Is there anything else?
Well, so I think the most powerful thing, as I say, for me, was that point where I was sort of like humming and hawing about whether to do anything about World Cerebral Palsy Day, and literally all I wanted to happen was the lights to go green. And then suddenly, out of nowhere, there was like everybody and their auntie waving green stuff about, and actually that was really nice and really powerful for me because I hadn't asked it, and that was really nice. And it was kind of that thing about, well, this is quite important to you, so we'll make it important to us. So that was nice. And I think just I would have the barriers thing, the sort of UN barriers healthcare is actually, I had a good read through that, and even as somebody who is disabled, I probably wouldn't have picked up on a lot of things that they mention, and it's very much from people's perspectives. So I think even if it's just in the back of your mind, these barriers, then that's really powerful to support and help patients as well. So I think that would be the thing to look at.
Thanks again, Kirsty.
Right, I know you need to get away, Kirsty, and Kerri
Thank
is
you.
jumping at the bit for the second half of the double act tour of Scotland.
Thank you very much.
So, Kirsty,
Thanks,
thank you so
Kirsty.
much.
Bye-bye.
Now, I've not met Kirsty before, but I've known Kerri for a long time as we worked together as registrars back in the dark ages. And now I'm lucky enough to work with Kerri through NES, as well, both associate postgraduate deans for medical specialties. And as I said, it was during one of those meetings when when Kerri just dropped in that she has this talk. So I've asked her along, and this padding has been enough for her to load up her screen. We can see your slides, Kerri. Looking forward to your talk.
Great, thank you very much for that kind introduction. Can I check you can still just see my slides without seeing presenter view?
You can, yeah, it is as you wanted it.
Perfect, that's great. So thank you very much for having me here today. It's difficult, a bit of a double act to be the second half of this talk. But anyway, we're going to move on from disability to gender, and I want to cover a bit of everything. I know there's not much time remaining and it might run on a tiny bit, but I'll fit within the half hour. We're going to talk about gender inequality and the experience for women on both sides as doctors and patients. So firstly, why did I choose to talk about this? Well, it stems from this. So this is a clip from a conference I was at in 2016. It was a Scottish conference from the Society of Acute Medicine. And they had an expert panel. And as you'll see, the expert panel had certain things in common. They were all men, they were all whites. And they were actually having a good laugh here because they were talking about the Chelsea model of care. And it was talking about Chelsea and Westminster model of acute medicine. But they found it hilariously funny that if you Google the Chelsea model of care, you get pictures of various beautiful women. And several slides were shared of those pictures of beautiful women by the all-male panel. And a few of us in the audience, I suppose, sat slightly dumbstruck and wondered what to do about it. And I'm ashamed to say it took me several years to decide what to do. So are things much better for gender equity 8 years on is the big question. And I'm going to take you on a bit of a whistle-stop tour about why the answer is probably no, and think a little bit about what we might begin to do about that. I think it would be remiss of me not to start with the really topical elephant in the room that everyone will recognise from the press over the last year, and that's sexual assault in the healthcare workplace. So you'll recognise these headline news, and you'll recognise that it comes from the sexual harassment and surgery paper that came out last September. So that was a big paper, over 1,400 responses, half from women, half from men. And it found that 63% of women and 24% of men had been the target of sexual harassment from colleagues. So 30% of women had been sexually assaulted by a colleague. 11% had forced physical contact related to career opportunities, which feels particularly slimy. And at least 11 were raped. So 11 women raped in the medical healthcare workforce at the workplace. And then it got worse. So this was a letter that was published the following day in the national press, and I'll read it to you. So it says, Sir, this snowflake generation of young women, largely female and selected on mainly academic excellence, clearly did not do their homework. Medical training and practice is brutal and demanding, with long hours, and bullying happens. Sexually inappropriate comments and actions do occur. It is stressful. All I can say is that if they want to make a success of this rewarding career, then they should toughen up. Perhaps 4 A stars at A-level are not the answer to all the problems they will face. Lots of love, Dr. Peter Hilton. So interesting use of passive wording about things happening rather than people doing things. And interestingly, this was an author who himself, I think, was very unlikely to have ever been the recipient of said sexually inappropriate comments or actions. And yet here's a man who, I guess, presumed his views would be so widely accepted and acceptable that he felt fit to publish it with his name against it in the Times newspaper. So moving on a bit from those thoughts, I want to look in a bit of more minute detail, because we've not really got time to explore the whole subject of sexual harassment. And actually, hopefully, you've already covered that in other topics. But actually, there's a much broader, more subtle picture that infiltrates throughout our workplaces and our lives. And the barriers go far beyond this sexual harassment. And much of it's invisible even to women. So that's what I've chosen to explore for the rest of the talk. So you sort of teaser there, be kind. This is what seems like a positivity movement recently. You'll see be kind slandered over people's pins and children's T-shirts and posters. And it might seem recent, but women have been conditioned to be kind since absolutely forever. So there's that old nursery rhyme about sugar and spice and all things nice. That's what little girls are made of. So throughout this talk, I do use some illustrations, and to keep them copyright free, I used AI, and I used a really common AI attachment called neural.love, which is used on the Chrome. So Google Chrome offer this up to you as a free AI producer of images and text. So it's widely found. And to use it, you just search your term or your description or whole sentence, and it will give you 4 images for free, and you can select which to use. So I've shown you the 4 images that neural.love offered up when I typed in be kind. And you'll see they're all of young women, and they're all pretty much in these kind of meek or subservient positions. So niceness and kindness is a real cultural expectation that's thrust upon women since childhood. And it continues fiercely on into their professional lives, where it's not without repercussion, and where we face the likability paradox. So the likability paradox is the idea that women must be liked in order to succeed at work, but they are less likable when they do. So to repeat that, if you want to do well at work, people have to like you, but then they won't like you when you do well at work. So for women to be considered confident and influential, she has to not only be viewed as competent, of course, but also has to be liked. And maybe unsurprisingly, the converse has been shown to be true for men, who become more likable as they climb the career ladder, and for whom exhibiting pro-social traits like kindness, niceness, helpfulness doesn't really matter in terms of whether they're going to be considered influential in their careers. So as women, we're in a double bind. We're expected to exhibit stereotypically feminine traits like kindness and empathy, but we're in workplaces where typically male traits like assertiveness are valued. And so women have to work harder to do and achieve both. This is Schrodinger's cat. This is not specifically Schrodinger's cat. This is my cat, Lulu, but Lulu is illustrating that all of this makes professional women into the Schrodinger's cat of personality traits, where we are simultaneously somehow more nice, but less likable. I'm going to back that up. So here's some demonstration of this likability paradox. So this is from a brilliant website called Gendered Language and Teacher Reviews. It's a website by Ben Schmidt in the US, and it has really fascinating interactive charts. You're all going to want to go and play on this later on. It's great. And it lets you explore the words that are used to describe female and male professors in about 14 million reviews from the ratemyprofessor.com that's used pretty widely in the US. So you'll see here, I've used those 2 words, nice and likable. In the y-axis, there's different disciplines and specialties, and I've highlighted health science. And you will see that they reflect the number of uses per millions of words of text for each word. Blue dot, of course, reflects male. Orange dot, surprisingly not pink, reflects women. And you'll see here that nice is a gendered word. So there are about 2,000 uses per million words of text to describe men as nice, but 2,500 uses per million words of text to describe women. And yet they swap when you enter the term likable. And actually, this suggests that the male professors are twice as likable as women. So it's not good enough to be just good at our job. We have to be kind and helpful and all things sugar and spice and nice. But for men, that's optional. And the problem is that the job of being a doctor and a leader is not necessarily to always be kind. It can be to challenge, to refute, to refuse, to disagree. And so the word kindness is disproportionately weaponized against women. And that makes the national guidance that's been brought out by GMC as a regulator pretty troubling, as there's an increased focus on likeness. And that may invite reporting to the regulator for those perceived to be less kind. For example, women in leadership positions. Unfortunately, I've not got time today to delve into race, but there are clear racial implications too around descriptors of nice and kindness, unfortunately. So in preparation to talk around the subject, I'd done a survey around South East Scotland of my peers, and I'll show you some of the data shortly, but the free text comments were really enlightening. And this one came back from a colleague who I really see is pretty top of her field. She is a medical leader in terms of she's got a management position, she's got a senior educator position. But this is what she told me. So she said, I've tried very hard to soften how I come across, because when I was younger, I think I was perceived as abrasive or bossy in a way that my male colleagues were not. This has meant I've become a massive people pleaser and get very anxious when I have to assert myself. So I find it hard to say no or to respond to someone robustly, and I get panicked by things that just require a firm answer. I have become a woman less sure of my opinions, plagued by self-doubt, who worries about offending or upsetting people all the time. So unfortunately, I can't do this bit in the room with people putting up their hands. This is normally a really good fun bit. But basically, I asked everyone, have they been called bossy at work in the same survey? And it was small. There were between 30 and 40 respondees. Roughly half were from women and the other half from men. And this is what they told me. So asking people were they called bossy, and well over half of women had encountered being called bossy. And interestingly, the majority of men had not. I asked them other terms. I said, have you been called feisty? And you'll see feisty is a term that for men is virtually never used, but over half of women had encountered that term. And then when I went back to rate my professor, I could see that this is clearly backed up elsewhere. So you'll see on the left-hand side there, bossy is a clearly gendered term. So half a use per million words of text for men and 2 uses, so 4 times as common for women. I couldn't find feisty because it's an American site. They used sassy, and there was a huge gender discrepancy there as well for sassy. So it occurred less than 1 use per million words of text for men and was 4.5 times more common for women. So these, believe it or not, are clearly gendered words. And then I wondered what AI would do, because AI is meant to be pretty smart and should be free from bias, one would have hoped. And I was pretty pleased, actually, because the search term I entered was bossy doctor. And it said the bossy doctor is a man. And I thought, oh, that's interesting. And then the penny dropped. And I changed my search term from bossy doctor to bossy person. So there she is. And then I looked for feisty person. There she is. And then I looked for sassy person, and no prizes for guessing, but there she is. Now, it was quite refreshing to see that not all terms were gendered. So things that were descriptors maybe of competence, for example, were less likely to be. So you'll see wise on the left here was pretty equal in terms of descriptors for men and women. But it very much comes out when people are describing personality traits. The women often seem to get the hard end of the stick here. So rude, you'll see, became a clearly gendered word across almost all specialties, interestingly, apart from engineering down at the bottom there. And when I asked my AI friend, you will see, so who do you think here is the wise person? Who do you think it suggested as the rude person? No prizes for getting this correct. I then asked people's experiences based upon this. So I asked my colleagues, do you get addressed as a nurse rather than a doctor? And every woman said yes. And you'll see the vast majority said this is a frequent event. So people see you and they assume you're a nurse. That is not just because we are someone wearing scrubs walking around the hospital, as demonstrated from the pie chart on the right, where the majority of men never encountered it. And the free text comments well and truly backed this up. So one said to me, when I'm on the wards, I get mistaken for a nurse by patients on a daily, if not hourly basis. Patients have asked me when they're going to see the consultant. I'm 58 and grey-haired, for goodness sake. And then another one, who was one of the few women of colour that I had in the workplace who was then able to respond, said this. She said, often, and occasionally the cleaner. There's definitely a gender-race intersection at play much of the time, and whilst I'd put my experience in the category of unconscious bias or microaggression, and I don't really think it's an intentional malicious thing, it's still exhausting at times. And I think it's very telling that that was the only person that responded to say they'd been mistaken for the cleaner, sadly. I then asked people, have you been addressed, have you found patients have addressed, a more junior member of the team instead of you when you're speaking to them? So think of the ward round with the team members with you. Every woman pretty much had encountered this. A third said this often happened. And the common examples were, I go around with a male medical student FY1 who is half my age, who has barely left school, and the patient addresses all of the questions to them and they ignore me as the consultant. Some men had encountered it, but that was just about the minority. Over half of men had never encountered this joy. I asked similarly, do you find that patients or the relatives say they've not seen a doctor yet when you've already spoken to them? Similarly, most women had encountered this and most men had not. And then finally, I asked the really obvious question. I said, do you feel that you've been treated in a sexist manner, intentionally or unintentionally, by colleagues or patients at work? And all women thought that they had been the majority often. You'll see here that some men had experienced that. No one thought it was a frequent event. And actually, for more than half of men, that had never happened. And the free text comments really were illuminating, some of them sad and some of them horrifying and some a bit of everything. So here are just a small proportion of the examples. So one said, in meetings, I have to really try not to be seen as emotional or histrionic. I think male voices tend to carry more gravitas and tend to offer the final word. And we know there's evidence behind that. For example, we know that Maggie Thatcher deliberately lowered her voice to be seen as having more gravitas. Another said, there's that thing about suggesting something which kind of gets ignored, only for everyone to think it's a good idea when a man states it. Several people told me the next thing, but this is one direct quote, which was, I get asked to perform administrative tasks and meetings and MDTs rather than my clinical opinion being sought. And there were loads of those people saying, I get told to bring in a cake, I get told to make the coffee, I get asked to keep the minutes. One said, I definitely get asked to do more junior tasks by nurses that I don't think they would ask of male consultant colleagues who are perhaps seen as less immediately approachable. And then one said, I have encountered sexual harassment during my training from more consultants than I can list. It was constant, almost expected, and ranged from drunken declarations of intent to sly comments, to nicknames being given to me based on how I look. As a young woman, this seemed like a normal part of working life, which is very hard to believe now. And it certainly wasn't seen as something to complain about. I am increasingly grateful to be disappearing into a middle-aged woman. But the interesting thing was, it was also really clear that sexist behaviour towards women was adversely affecting male colleagues too. So here are some examples. One said, as a student, I was aware that the attractive female colleagues would get invited to theatre more often and scrubbed in. Teaching would be directed at them. And sometimes you'd feel like you were sat in on someone else's tutorial. But this special attention often made those individuals feel uncomfortable and would be accompanied by brushing past or light touches on the lower back of forearm. Another said, some male patients expect me to join in with, or at least appreciate, their comments about female staff appearance. And one male consultant colleague of mine said, recently I met a female colleague in the corridor who's clearly upset. She explained that she had been told by another woman that she was overly emotional in an interaction with the patient and to be more professional. My reflection on this, as the male colleague, is that on occasions where I've been emotionally affected by an interaction with a patient, cried in a consultation, or been visibly upset, the immediate feedback I received was how great or impressive or wonderful it was that I was so emotionally invested in my patient. So, is sexism just in the clinical workspace? You're not going to be surprised that I'm going to say no. This paper from summer 22 found that women are credited less in academic science than men. And the authors concluded that women are less likely to be credited because their work is often not known, not appreciated, or simply ignored. So think of Rosalind Franklin here, who discovered DNA alongside Watson and Crick, but is a much lesser known name. And then even when women are credited, they may not be believed. So this was a big surgeon sex and long-term postoperative outcome study from last year. It was a cohort study of over 1 million patients. And it found that those treated by female surgeons were less likely to die and less likely to suffer a major medical complication and less likely to be readmitted. And that association was seen across almost all subgroups, defined by, amongst other things, procedure characteristics. Is it just seen in surgery? Well, no. There was a 2016 study by Harvard that looked at the inpatient admissions for more than 1.5 million hospitalized Medicare patients that were treated by general internists. And it found that elderly hospitalized patients treated by female internists had significantly lower mortality and hospital readmission rates than those treated by male counterparts. But back to this study, so back to the one from last year about surgeon sex. So this was the immediate response by the president of the Royal College of Surgeons of England, who, to be fair, has subsequently retracted the statement. He said these are interesting results which add to the growing literature suggesting that there are differences between the outcomes for male and female surgeons. However, association is not causation, and one possible explanation may have to do with case complexity. The authors have tried to take the case mix into account by adjusting for confounders, but residual confounding factors cannot be ruled out. So interestingly, his knee-jerk response, and I think you can tell a lot by someone's immediate response that doesn't involve deeper thought, was that probably the women were just getting the easier operations to do, rather than maybe thinking, for example, that female surgeons may achieve better outcomes because of the years of discrimination and bullying and harassment that they go through that then exclude all but the very highest achievers. So where are we now? Well, again, when I was looking for illustrations, I wanted to find some for Professor. So these are the stock image options in PowerPoint for Professor. And you'll see, interestingly, that all but one illustrate women, and most are women of colour. This is lovely, but it's a bonkers dream world. It's not remotely representative, unfortunately, of where we are in any way, shape or form. So in the UK, 44% of doctors are female, including 55% of medical students, 54% of trainees. So if we continue in this trajectory, then women will make up the majority of the medical workforce within the next decade. However, only 32% of consultants and 24% of medical directors are women, and women are underrepresented across basically all leadership and academic roles. Women of colour are even more underrepresented. They make up 0.1% of professors in the UK in terms of being Black women. So nothing, unfortunately, like the stock images that are suggested here. And when we look at world data, according to WHO, an estimated 75% of leadership roles in health and care are held by men. But the converse is that 67% of the health and social workforce around the world are women. So there's a clear imbalance there. So why are there more women at the top of medicine? Well, alongside everything we've considered, there's also plenty of evidence that women are less good than men at self-promotion. So women are less likely to self-nominate for pay awards, so less likely to get discretionary points or CEAs, for example, and that contributes to the gender pay gap, where an average female positions in the UK and the US are earning approximately £15,000 to £20,000 less per year than their male colleagues. Women are also unlikely to apply for jobs if they don't reach 100% of the specified or desired criteria, whereas men will apply when they meet 60%. So women are less likely than men to self-nominate for managerial and leadership positions. And then women in leadership also face ageism at every stage. So in this study from last year, the authors concluded that they found no age was the right age to be a woman leader. They said there was always an age-based excuse to not take women seriously, to discount their opinions, or to not hire or promote them. So is it any surprise that fewer women reach leadership positions at all? So I put it to you that organisational culture, including sexual misconduct and discrimination, are only going to change if there's more women at the top. And it's not just about changing discrimination. There's clear evidence that having greater gender equality and having women at the top of organisations, not just in medicine, but in the broader fields of business and science, results in broader economic benefit, enhanced productivity, increased innovation, and improved culture and organisational performance for everyone involved, regardless of gender. So everyone benefits, including men. Anyway, that's plenty about doctors in the workplace, and I know we've not got time really, but I wanted to quickly think about, is it as bad for women as patients? And I want to highlight Brave Men and Emotional Women, which is a brilliantly titled 2018 literature review, which found that doctors often view men with chronic pain as brave or stoic, but view women with chronic pain as emotional or hysterical. It also found that doctors were more likely to treat women's pain as a product of mental health rather than physical condition compared to male patients. And around that time, there was a big survey of doctors and dentists in the UK, and it found that healthcare professionals routinely believe that women exaggerate their pain, despite 40% of the respondees being women themselves. Some examples here are around the gender data gap. And the gender data gap is the failure to collect data according to gender because the male view of the world is the normalised one. So women are either not actively recruited into studies, and we know they're less likely to participate in standard studies, probably due to the burden of caring responsibilities around the world, or women are actively excluded because of potential interference by pesky hormones at the risk of pregnancy. And that results in absent presence and a world that's built on data gathered almost exclusively on men whilst being passed off as gender neutral. So women are once again Schrodinger's cat. We are simultaneously too complex to include, but also simple enough to deduce from male data. And then furthermore, data is usually sex aggregated, so it fails to recognise that there are differences between male and female bodies, and they just aren't the same. So there are fundamental sex differences in lung capacity, mechanical workings of the heart, blood vessel aging, drug metabolism, gut transit time, renal filtration. I could go on. So I've used atypical chest pain as an example here because cardiovascular disease is the top cause of death of women in the US, the second cause in the UK after dementia. And following an MI, women are significantly more likely to die than men. Young women are twice as likely to die in hospital because of it. And yet only 1 in 8 women report the typically classical male symptom of chest pain. So why on earth is their presentation atypical is the big question. And yet women are 50% more likely to be misdiagnosed following an MI because they present with these atypical symptoms like abdominal pain, breathlessness, and nausea. We know that women wait longer for an ambulance. They wait longer to be seen in the emergency department, and they're twice as likely to be diagnosed with a mental illness when complaining of symptoms compatible with a heart attack than a man with identical symptoms. Why? Most research in cardiovascular disease has historically been on men. Also, we don't believe women. ADRs I've listed because in 2002, the FDA Centre for Drug Evaluation and Research showed that there were statistically significant differences between men and women in bioequivalence for most generic drugs compared with reference drugs. But the FDA denied the systemic underrepresentation of women because women make up almost 50% of those in phase 2 and phase 3 clinical trials. However, women were only 22% of participants in phase 1 trials. And if, as according to the FDA, the second most common ADR in women is the drug simply doesn't work, then how many drugs that might work for women were ruled out of phase 1 trials simply because they didn't work in men, and men made up the 80%. And then finally, I've got women's conditions there. So endometriosis affects 176 million women worldwide. That's 1 in 10. But it takes an average of 8 years to diagnose in the UK. It has no cure. And NICE only released guidance about it in 2017. PMS affects up to 90% of women, but there are 5 times as many studies on erectile dysfunction and really still very little treatment available. So in medicine, we love to refer to the evidence base, which sounds fine, and it's not malicious in intent, but it's inherently biased. Just last summer, this study, we discovered that women are more likely to regain some sort of consciousness during an operation because they respond differently to anesthesia. But if they had used a standard approach of sex disaggregated data, would this have been discovered sooner? I think almost undoubtedly yes. But that problem's almost often ignored or even denied. There's research that shows that male academics in STEM have rated fake research, claiming that academia has no gender bias, higher than real research, which shows that it does. And there's numerous studies from around the world that show that women are less likely to receive academic funding, they're less likely to be granted meetings with professors, and they're less likely to be offered academic mentoring to comparable males. So, what can we do about it? So the first is, I think we do need more women in senior leadership positions, and hopefully I've shown you that is good for everyone. But to do that, we can't have a typical male approach. We can't keep saying, just nominate yourself, because that really is saying, just be more male. And that doesn't work when it's half the population. So we need to take a different approach. And approaches can include things such as opt-out promotional schemes. So should people automatically be contacted and told it's time to apply for your discretionary points, for example? Should we have a tap on the shoulder approach? A tap on the shoulder, I think, is really potent for women. So that is when you identify someone you think would be great and you physically tell them in the knowledge they are less likely to put themselves forward. So the WhatsApp conversation on the right was a conversation that happened for myself and one of my own wing women when the Dean of Education role came at RCPE a few years ago. And I deleted the email when it came out because I thought I did not have a cat's chance in hell of anyone wanting to give me that job. And she kind of niggled at me for a couple of weeks and kept saying, I think you'd be really good. You should go for it. I think you'd be great, until I went for it. And then this is the conversation where I got it. And she said, you're the best man for the job, though you're a woman. So I really encourage that approach. Lift as you climb is similar. It is as we get more senior, we have more opportunities that we can pass down the ladder. And we should be choosing to pull people up behind us. And I think we need to pull everyone up behind us. But there can be some positive discrimination in terms of how we actively encourage, recognizing that some people may be more or less likely than others statistically to put themselves forwards. Mentoring, again, really similar. So giving people a voice, empowering people to make changes. I've said a zero tolerance approach to sexual harassment, and that I think is pretty obvious for organisations, but it will require a massive change in culture, whether organisations like to recognise there's a problem or not. In terms of what you can do as an individual or as a department, active bystander training, which Kirsty's already referred to, can really help empower the workforce. And having codes of conduct can hold the workforce to account, and it can empower managers to do so as well. We need to study and teach gender differences. So I've not had time to talk about it today, but there's brilliant evidence that misrepresentation or underrepresentation of women in textbooks and teaching has significant impact on people's career choices and also on clinical outcomes in terms of examination findings, for example, missed cardiovascular exams in women. So we need to teach on both. Researchers, please actively recruit women and men in equal parts and report sex disaggregated data. You may find a fantastic breakthrough that no one had noticed otherwise. And then at conferences, let a woman ask the first question. We know if a man asks the first question, women are significantly disinhibited from getting up and asking. But if a woman asks the first question, the subsequent women are between 10 and 20% more likely to ask a question, and there's no adverse effects on the men in attendance at all. So everyone wins. And then finally, stop misrepresenting women. So language matters. I think I've shown you there, hopefully, that we need to be mindful of gendered words and how we use them, and then how we put that into things like job adverts for promotion. So studies show that women are put off from applying for jobs that use stereotypically male words such as ambitious, but also that they don't consciously note the language or realize the impact it's having on them, which just goes to show that you don't have to realize that you're being discriminated against to actually be discriminated against. And then finally, I've said show women at the top. So that visibility is incredibly important. That's the you've got to see one to be one that, again, Kirsty talked about. And that is the same for every characteristic that intersects with that, particularly race. And then finally, please, most importantly, believe women. So believe and support those who report sexual harassment, assault, discrimination, bias. We know that false accusations can happen, but they're actually really rare in practice. And very importantly, believe your patients. If your patient and your textbook do not align, I ask you to ask yourself this: is the problem with your patient or with your textbook? Thank you.
Thanks very much, Kerri. I don't really know how to follow, to be honest. I think that was an amazing talk, and a few people have messaged me independently during your talk just to say, who is this? And this is a really powerful thing, and I can only just pass those messages on. I think that was a very, very powerful talk, and
that's very kind. Thank you.
And it's of no surprise to me that you would give such an amazing presentation, having known you for as long as I have.
Thanks, Tom.
Now, there are a few comments down in the chat. Karen says, incredible work, thank you. Claire Webb has said, last year I submitted an FOI request for East of Scotland Deanery multi-consultant report scores separated by anonymised consultant gender of SSE. NES EOS Deanery JRC PTB said no, they didn't have to, because the JRC PTB is not a body obliged to respond to FOIs, and the other passed it to them. I would still be interested if you think, as I do, that this would be a valuable information to inform assessors of unconscious biases, and if you have any suggestions on who could authorize it to be collected and released.
Thanks, Claire. I think that's a great comment, and it's something I've thought about every year. So one of my roles has been as a TPD for almost a decade, and so I look at a lot of MCRs and MSFs, and I've often wondered if we could do this, and actually haven't got as far as you have into looking into it simply because of time. But I think it would be an amazing project, because I think we would find that there are lots of gendered words and gendered expectations. But I don't know how we access it, because there is so much protection around confidentiality and GDPR that is pretty rock solid. I suppose, could we ask trainees to voluntarily let us use that information, perhaps? And maybe that's where that would come from, is could we have a subset of trainees that say, I consent to my form being used, and willingly give up the data themselves? Because I don't see that there could be any opposition to that. But I would love to do something like that. I think it would be absolutely fascinating. And probably quite damning.
Indeed. Some more comments just thanking you on the talks. As Icky said before, after Kirsty's talk, and I think you've answered this in the talk already, to be honest, his question was, apart from active bystander training, etc., and trying to be allies in this, I think what's your advice to me as an ally? What's your advice to me to be able to make change and call out these problems?
So I think being alert to it, because most of these things are pretty invisible. And actually, I have a much longer version of this talk, and there's so many things. So I see people have talked about professorships, and I mean, there's so many ways in which it happens, but it's not obviously sexist. So yes, obviously we want men to call it obviously sexist behavior, but a lot of these things are almost invisible, including to women. So women don't realize they're happening as well. So partly it's encouraging people to teach about it so we can see where the subtle areas are. You know, if you see someone grope your colleague, you know that's a problem. You might not realize there's a problem with the advertising for some wording for a promotion, for example, though, because that is really subtle. So teaching about it definitely raises awareness. So I've raised a feminist in my household. I don't have a child, but I have a husband who now will spot all sorts of things and point it out before I remotely see it. So definitely he's learned and is really actively watching for it. But I think the tap on your shoulder thing, for me, I've always found really powerful. So I think imposter syndrome is there for everyone, regardless of gender. But we know women are less likely than men just to have a go on something. They're more likely to feel embarrassed. And I think it's great that men will go for a job when they reach 60% of the criteria. It's really ballsy. I love that. But women are just not going to do it. So they do require someone to say, hey, do you know what? I've seen this opportunity. I think you're great. Why don't you go for it? And I really actively try to do that now. So when I see adverts come out for council positions or training positions, I don't just presume someone's going to read the email and go for it. I actively think, who do I know that would be really good for that job? And this is women and men, but probably I'm more likely to approach women because of this bias. And I will message them and say, have you seen this? I think you'll be great. Nez is doing a lot of work around this. And as you'll know, Nez actually has a really good gender balance. So Scotland is kind of catching up, but Scottish universities have not caught up. Scottish medical schools have not caught up. So there's a lot of work to be done around the country still.
I'm glad you clarified about raising a feminist. I thought you'd raised a feminist cat.
My cats are absolutely feminist. You've seen my Schrodinger's cat already.
Right. We've overrun, but it's been absolutely delightful to do so. And at least 20 people have stayed around to listen to the end of the talk. So I think that just shows how people are very interested in this and really enjoyed it. This talk will go onto YouTube once I've edited it. And just thanks very much for taking the time. Kirsty, who's not here anymore, and Kerri for coming to talk to us. Really fantastic, thought-provoking stuff. Thank you. Right, so next week, I can't remember what's in the programme next week, so I'll email out when. Oh, I do remember. Alex Doney is going to come from Memo to talk about pharmacogenetics and the pharmacogenetic research that's been carried out at the University of Dundee and is rolling out into NHS Tayside, and he's going to give us an update on that. Then we have a brief hiatus before Grand Rounds returns in July. So thanks very much again. Enjoy the rest of your days and your weekends, and take care, everyone.
Thanks, everyone. Thanks for having me.